Hey, my name is PiggyChemist, your AI pharmacy educator. And this is Pody, a pharmacy student, and the real brain behind the research. Each week, Poby researches a health topic, writes a report, and together we turn it into a video. Real research AI. Today, I'm breaking down iron supplements. We'll cover why iron matters, who's at risk, how to spot deficiency, which blood test to ask for, picking the right supplement, taking it for maximum absorption, drug interactions, recovery timelines, common myths, and when to see a GP. Let's start with why iron matters more than most people realize. Most people think iron is just about preventing anemia, but that's only part of the story. Low iron affects your energy, your muscles, your immune system, and your brain. Most of those symptoms look like dozens of other things, so people spend months chasing the wrong diagnosis, trying random supplements, questioning their thyroid. Getting iron right starts with understanding what it actually does. Iron does four major things. It carries oxygen in your blood through hemoglobin, it fuels your muscles directly through myoglobin, it powers your immune cells during infection, and it supports dopamine and serotonin production in your brain, which is why low iron causes brain fog. Here's the catch. The body has no active way to get rid of excess iron. Absorption is tightly regulated at the gut by a hormone called hepcidin, which rises when stores are full and drops when stores run low. Australian daily iron requirements. Adult men need 8 milligrams a day, premenopausal women 18, pregnant women 27, teen girls need 15. Toddlers also need a surprising amount relative to body size because they grow so fast.
27 milligrams. I'm eating a single steak and calling it a day.
Here's where it gets personal. Who's actually at risk? Iron deficiency is one of the most common nutritional deficiencies in Australia. Certain groups are far more vulnerable than others. If you fall into any of these categories, don't wait for severe symptoms. Get tested. Early detection saves you months of feeling awful. The tricky part is that many of these groups look perfectly healthy from the outside, so people assume they're fine until they're not. 7 high-risk groups: women of reproductive age, monthly blood loss. Pregnant women, fetal demand is massive. Vegans and vegetarians, plant iron absorbs poorly. Toddlers, 6 months to 2 years, rapid growth. Endurance athletes, foot strike hemolysis. Frequent blood donors, 250 milligrams iron lost per donation. And anyone with celiac, Crohn's, or post-bariatric surgery, because absorption is impaired regardless of diet. Notice that even perfectly healthy-looking people can be in one of these categories. Iron deficiency doesn't care how fit or organized your diet looks.
Iron deficiency doesn't happen overnight. It builds in 3 stages.
Stage 1. Depleted stores. Your storage iron is running low, but transport iron is still fine, so blood work looks mostly normal. Most people feel nothing or just a bit tired. Stage 2. Iron-deficient erythropoiesis. Your bone marrow isn't getting enough iron to make healthy red cells. Fatigue and brain fog kick in hard. Stage 3. Full iron deficiency anemia. Hemoglobin drops and you get the classic picture. Pallor, breathlessness, dizziness. Exact blood values for each stage. Ferritin drops first, long before hemoglobin moves. That's why ferritin is the single most important number to check. Now, the symptoms you should actually be watching for. 8 common symptoms. Persistent fatigue that doesn't improve with rest. Pallor, especially in the inner eyelids and nail beds. Shortness of breath on mild exertion like stairs. Dizziness when you stand up quickly. Heart palpitations. Frequent dull headaches, cold hands and feet, trouble concentrating, the brain fog many people just call feeling off. 5 sneaky symptoms most people don't connect to iron. Pica, craving non-food items like ice, dirt, or chalk. Restless legs at night, diffuse hair loss often blamed on stress, spoon-shaped brittle nails, and a smooth, sore red tongue called glossitis. Any of these with fatigue, ask for a ferritin test.
I have been chewing ice for a month. I thought I was just a hydration person.
Many of these symptoms overlap with stress, poor sleep, thyroid issues, B12 deficiency, even early pregnancy, which is exactly why a blood test is the only way to know for sure.
How do you actually get diagnosed? Here's exactly what to ask for.
Before you buy any iron supplement, please get a blood test first. Fatigue has dozens of causes. Thyroid, B12 deficiency, depression, sleep apnea. Self-treating with iron when you don't need it wastes months. Ferritin testing is commonly covered in Australia, but ask about any out-of-pocket cost before your appointment. And ask for it specifically, because your GP may not order it unless you do. The main test to ask about is ferritin. It drops first and is the most useful marker for iron deficiency. A full blood examination catches established anemia. In more complex cases, serum iron with TIBC and transferrin saturation help interpret the results, and CRP can flag inflammation that distorts ferritin. If you remember one thing, ferritin, your full blood count can look completely normal while you're in stage 1 or 2 deficiency, because hemoglobin is the last thing to drop. Ferritin is the first. If your GP only orders a full blood count, specifically ask to add ferritin. One trap to know, ferritin is what's called an acute phase reactant. It rises during inflammation, infection, or liver disease. So if your CRP is up and your ferritin looks normal, your real iron stores could still be low. Any good GP will interpret ferritin alongside CRP.
Ferritin! 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 I'm writing it on my hand before the appointment.
Once you've got a diagnosis, the next question is which supplement? Walk into any chemist and you'll see a full wall of iron products at wildly different prices. Most of the price difference doesn't buy you more iron. Let me show you what actually matters when you choose. Before brands, one number, elemental iron. The big milligram figure on the front of the box is the total compound weight, not the iron you absorb. A 325 milligram ferrous sulfate tablet only contains about 105 milligrams of elemental iron. Always check the elemental figure on the label. The 5 main iron types you'll find in Australian pharmacies: ferrous sulfate, ferrous fumarate, iron polymaltose like maltofer, ferrous gluconate, and iron bisglycinate. Each differs in how much elemental iron it delivers, how gentle it is on your gut, and how much it costs. Walking into a chemist, you'll see a wall of options. The most expensive one isn't automatically right. The best match depends on your deficiency severity, your gut tolerance, and your budget. Quick decision guide: moderate to severe iron deficiency anemia, go with ferrous sulfate. Strongest evidence and cheapest. If ferrous sulfate gives you constipation or nausea, switch to iron polymaltose like maltofer taken with food. IBD or very sensitive stomach, bisglycinate is the premium gentle option. Maintenance after recovery, ferrous gluconate at a low dose is enough. Now, how to actually take iron for maximum absorption? Standard therapeutic doses for adults with iron deficiency anemia: 100 to 200 milligrams of elemental iron daily until hemoglobin normalizes. For maintenance after recovery, 18 to 30 milligrams daily is plenty. Pregnant women, the daily iron requirement rises to 27 milligrams, often met through diet plus prenatal vitamins. Routine high-dose supplementation isn't recommended for everyone, only if blood work shows deficiency. For children and pregnant women needing treatment, dosing must be individualized by a GP or pharmacist. Specific pediatric or pregnancy doses aren't general advice. Taking iron is more than just swallowing a tablet. 5 rules genuinely move the needle on how much you actually absorb. Get these right, and you can double or triple your uptake. Get them wrong, and you might as well flush the tablet. In pharmacy practice, we see people who swear their iron isn't working, and 9 times out of 10, the issue is one of these 5 rules. Rule 1: empty stomach, 30 to 60 minutes before meals. Rule 2, pair with vitamin C. A glass of orange juice or 200 milligrams can boost absorption 2 to 3 times. Rule 3, separate from blockers. Tea, coffee, dairy, calcium and antacids at least 1 hour apart. Rule 4, single daily dose is as effective as split doses and much easier to remember. Rule 5, dark or black stools are normal on iron, not a sign of bleeding. But if your stools are tarry and sticky and you feel dizzy or weak, see a GP. That could be actual GI bleeding. Cheat sheet you can screenshot. What helps iron absorption on one side, what blocks it on the other. One more decision. Daily versus alternate day. Dosing. Every other day is emerging from recent research as equally effective for many people with fewer GI side effects. The science is about hepcidin, a hormone that spikes after each dose and blocks absorption of the next one. Skipping a day lets hepcidin reset.
Coffee with my iron tablet every morning for 3 months. I'm the problem.
Think of absorption like a funnel. If you time it right with vitamin C, most of it gets through, mix it with coffee or calcium, and most of it just washes past. Iron doesn't just interact with food, it interacts with several common medications. Iron forms insoluble complexes with certain drugs in your gut, and that's called chelation. When it happens, both the iron and the other drug get poorly absorbed, so you lose the benefit of both treatments. The fix is simple. Time separation. Space your iron and the other medication by a few hours. Main drugs to separate from your iron with exact separation times. Thyroxine like Utroxig or Oroxine needs a full 4 hours apart. Fluoroquinolone antibiotics like Ciproxin 2 hours before or 6 hours after iron. Bisphosphonates for osteoporosis like Fosamax 2 hours. Levodopa for Parkinson's 2 hours. Antacids and PPIs like Losec 2 hours. Screenshot this. In practice, people find it simplest to set a phone alarm, iron at breakfast, thyroxine at bedtime. That one habit change fixes most interactions overnight. How long does recovery actually take? The honest answer surprises most people. 3 phases of recovery. Weeks 2 to 4. You start feeling better as hemoglobin begins rising. Energy lifts, headaches ease, breathlessness improves. Weeks 6 to 8. Hemoglobin fully normalizes on blood work. This is when most people stop, and it's a mistake. Months 3 to 6. Your ferritin, the storage, is finally rebuilt. This is when you're actually done. The single most common pharmacy counter issue. People stop iron the moment they feel normal. They quit at 6 weeks and 3 months later they're back, exhausted, starting from scratch. Think of it like charging a phone battery. Feeling okay again is 10%, not 100. Don't pull the charger just because the screen turned on. 3 to 6 months later, the difference is night and day. Stairs feel easy, brain fog clears. You wake up rested. This is what actually recovered iron levels feel like, not just baseline survival.
Stop taking iron at 6 weeks? Me? I would never. I totally did.
When can you manage iron yourself, and when do you actually need a GP? Self-treat. If you have a recent blood test confirming mild deficiency, if you're a menstruating woman with known heavy periods and low normal ferritin, or if you're vegetarian maintaining levels. See a GP first if you're a man of any age with iron deficiency. You need to rule out gut bleeding. See a GP if you're pregnant, if your ferritin is under 10, or if you have any rectal bleeding, weight loss, or abdominal pain. These last 3 can signal something serious. Before we wrap up, I want to clear out some stubborn myths about iron. Some of these are grandmother advice, some are online nonsense. All of them cost people real recovery time. These are the 6 iron myths that come up most often at pharmacy counters. Each one costs real people months of recovery time. We want to walk through them quickly so you can spot the wrong information the next time you hear it online, in a magazine, or from a well-meaning relative. The pattern with all of these is the same. They sound obvious, they feel intuitive, and they send people down the wrong path for months at a time. Myth 1. Tired means you need iron. Reality, fatigue has dozens of causes. Get tested first. Myth 2. Spinach fixes iron deficiency. Reality, plant iron absorbs poorly and spinach's oxalates block it further. Myth 3. Expensive supplements work better. Reality, ferrous sulfate has the strongest evidence for IDA. Myth 4. Normal blood test means done. Reality, hemoglobin normalizes long before ferritin. Myth 5. Empty stomach is always best. Reality, if it causes nausea, take it with food. Adherence beats perfection. Myth 6. Men don't need to worry about iron. Reality, iron deficiency in adult men often signals GI bleeding. Always see a GP.
I believed 4 of these, possibly 5. I'm not proud.
One quick safety note. Iron tablets look like candy to young children, so keep them in child-resistant packs up high and out of reach. If a child swallows any, call Poisons information immediately on 13 11 26. Here's what to take away. Iron does far more than prevent anemia, while it powers your muscles, your immune system, and your brain. Always get a blood test first and ask specifically for ferritin. Match the supplement to your severity and your gut, not the price tag. And when you start feeling better, keep going. That's when the real recovery is happening underneath. Simple rules, big difference over time. The 5 rules to remember. Get a blood test, ask for ferritin specifically, match the supplement to your severity and your gut, not to the price tag. Take it on an empty stomach with vitamin C, separate from tea, coffee, and calcium. Keep taking it for 3 to 6 months after you feel better, because that's when your stores actually rebuild. And screenshot any of the tables in this video you want to keep on your phone. A quick disclaimer, this content is for education, not medical advice. Always check with your pharmacist or doctor. Full sources are linked in the description below.
If this was helpful, a like and a subscribe goes a long way. It helps more people find clear, reliable pharmacy information. Drop your questions in the comments. See you in the next one.